we might make a start. Thank you everyone for coming tonight. I'm a stand-in facilitator, so we'll see how this goes. I haven't done facilitation of a panel discussion before, so hopefully we, well, I don't make too much of a mess of it. I'm sure our three esteemed and highly qualified speakers will make a good job of it. So I'd like to start by welcoming everyone to our Research Matters Stroke Week event for 2024. This is the third one in our series of 5, so in 3 weeks' time we have one on women's health, if you're interested, so that'll again be on a Wednesday night. You can go to our website to find details of that. And then a bit later in the year we have another one on, it's to do with sleep, and I'm not sure if we've finalised the date yet, but keep an eye out for that one. I'd like to start by acknowledging the Muanina people, the traditional custodians of the land we've gathered on today, pay respects to Aboriginal elders past and present. For those who haven't met me, I'm John Stubley. I'm the interim CEO of the Royal Hobart Hospital Research Foundation. I'm filling in for Steph Furler, who's on 7 months of maternity leave, and Steph will be returning at the end of September. So Royal Hobart Hospital Research Foundation raises funds to support innovative medical research projects in Tasmania, and we focus particularly on the health and wellbeing of Tasmanians. St Luke's are very generous to allow us to make use of this room, and we certainly acknowledge that they are an organisation that is working towards the same goals as the Royal Hobart Hospital Research Foundation. They're particularly keen to do more than offer health insurance, but to help people with their health. This is a wonderful space that has not been open all that long, so I'm not sure how many of you have been here before, but I was incredibly impressed when I first stepped in here a few months ago. We're thrilled to have so many local health and medical researchers supporting us in one room here tonight. We hope this series of events helps educate and inform those passionate about the wellbeing of their fellow Tasmanians and improve our community's health literacy. It's a chance for you to connect over the next hour with some of the foundation-funded researchers and the projects they're passionately working on. So I invite you to sit back and enjoy tonight's discussion as we explore the fascinating discoveries being made locally in stroke research right here in Tasmania. And I, prior to my time with the foundation, hadn't had anything to do with medical research. And the one thing that has struck me since I've been involved with the foundation is just how passionate the researchers are in the work they're doing. It really is a calling and not just a job. So strokes are leading cause of death and disability, significantly impacting the quality of life of many Tasmanians. Tonight we've gathered an expert panel to shed light on this pressing issue. Our discussion will delve into the complexities of stroke management and exploring the latest advancements in research, prevention strategies and in innovative treatments. Before we begin, allow me to introduce to you our special guests who have dedicated their careers to advancing our understanding and treatment of stroke. Their invaluable research and clinical work is making significant strides in combating this condition, offering hope and improved care for many Tasmanians. Firstly, we have Associate Professor Seana Gall in the middle, who will Seana. That's okay. Who will discuss her I told you I'm a beginner at this. Discuss her research on secondary prevention of stroke and the evaluation of the Stroke Outreach Program, otherwise known as STOP. Next we're honoured to have Dino Premilovac. Yeah, really? Wow. Whose work focuses on the neuroprotective effects of idebenone.
Yep.
And I've asked him to explain to us what that is when we get there. And innovative drug delivery methods. Finally, Gary Morris, Dr. Gary Morris, will share. Yeah, I got that one covered. Will share insights into his development of a blood test for detecting microvascular injury post-stroke. So we'll start with Seana. What are the primary causes of stroke that you've identified in your research.
Yeah, great. Thanks. And hi everyone. Nice to see you all. Hope you can hear me. There we go. Yeah, so I think our first lot of questions is all around the risk factors for stroke and how we can prevent stroke. So the first thing to say is that most strokes are preventable. They're mostly caused by what we call modifiable risk factors, and I think Dino's going to talk a little bit more about those, so I won't steal too much of Dino's thunder, but what I will talk a little bit about is in the language we use so I'm an epidemiologist, so we do studies of people that have had strokes, looking at things that cause people to have a stroke. We also look at people's recovery and things that can influence people's recovery. And in the world of epidemiology, we like to give things, names that are understandable to us, but not necessarily to other people. And so we often talk about modifiable risk factors, so things that we can do something about by changing behaviour or taking medications. And then we talk about what we call non-modifiable risk factors. And these are kind of things that we have or inhabit as people that are difficult to change at first glance. So one of the biggest risk factors for stroke is age. So as people get older, the risk of stroke greatly increases. And this is for lots of different reasons, but a lot to do with the kind of accumulation of lots of risk factors over people's lifetime. So having, high blood pressure, not necessarily hypertension, but certainly having higher blood pressure across your life, that causes damage to the blood vessels over time that can increase the risk of stroke. The other thing, which I've done quite a lot of research on, is differences between men and women. So most statistics you'll see say that men have a higher risk of stroke over their lifetime, and that's true when you look across all of the life, but there's also certain points in a woman's life when she's at much greater risk than other women, but also compared to men. So certainly in the period around pregnancy and childbirth is a heightened risk for a woman to have a stroke. And then we also see in the period between transition to menopause, and then in the very older ages, women seem to be at higher risk. So that's one of those sort of non-modifiable risk factors we talk about. And then the other thing we've been doing quite a lot of research in is looking at socioeconomic factors. So we've been doing research here in Tasmania to understand the incidence of strokes, so where strokes are happening in the community. And we know that people that live in more disadvantaged communities are at about 20 to 30% higher risk of having a stroke than those in our most advantaged communities. So there's some of the risk factors that we have been looking into around our research. But I do want to end by saying, even if you have all those risk factors, if you're doing all those other good things to modify the other risk factors, you can really bring your risk down. And so that's an important message to have at the end.
Okay, thanks, Seana. So I guess leading into that, I've got this listed as a question for Gary. How do modifiable risk factors
Gary's question. I thought it was your question.
contribute to the likelihood of experiencing a stroke? And it's interesting that some communities are at higher risk than others.
Yeah, and I think Seana gave a really neat introduction into modifiable and non-modifiable risk factors for stroke. I'll probably talk a little bit mainly about modifiable risk factors. So high blood pressure or hypertension was one of the ones that Seana featured. And if you look at the statistics, these are something like a little bit of high blood pressure can give you 2 or 3 times the risk of developing a stroke. And it's similar for something like diabetes or having high cholesterol. What I wanted to sort of talk a little bit about is why those are actually risk factors for stroke. It's quite clear that they are. But what we sort of think about a little bit is the effect that these risk factors have on your blood vessels. Because effectively what happens in a stroke is, as we all know, it's a plumbing problem. We have something blocking a blood vessel in the brain. What that something is generally something like a blood clot or a piece of fatty deposit travelling up a blood vessel and getting caught generally at some sort of junction in the brain. So these risk factors for stroke, like for example hypertension, that can cause blood vessels to become weaker, and because also the blood is travelling fast, it can cause things to break off blood vessels elsewhere in the body, and they can then travel up into the brain and get lodged in the brain. And something like diabetes, for example, can increase the amount of fatty deposits in the walls of blood vessels around the body. So this is a little bit of the research that I more focus on the downstream consequences of a stroke, but this is precisely how these sorts of risk factors influence a stroke.
Okay, thank you for that. So Dino, Tasmania has some of the highest rates of stroke in Australia. genetics play a part in that? And if so, what are the reasons for that?
Yeah, thanks everyone, and thanks for the opportunity to speak tonight. So genetics and stroke aren't inherently linked to each other. So you're not born with necessarily an increased risk of stroke because of the DNA that you have inside your body that you inherited from your parents. The thing that increases your risk of stroke from a genetic point of view is having an increased risk of becoming obese or diabetic or having higher blood pressure. So there are genetic risk factors that increase the comorbidities that Seana and Gary have spoken about. That means that you're more likely to have a stroke because you've got more risk of developing high blood pressure or diabetes. But there's very little reason, or there's very little evidence to suggest that any genetic predisposition exists for you having a stroke. The only exception to that is if you have some sort of genetic modification. Is this working properly? Can everyone hear me? Is if you have a genetic modification that changes how your blood clots. And that's really the only real genetic kind of underlying risk factor for stroke directly. Now, that is not overrepresented in Tasmania. So there is no underlying genetic cause that is driving increased risk of stroke in Tasmanians. Largely, it is driven by the factors that Seana spoke about and Gary spoke about. The modifiable risk factors are one of the primary drivers, where obesity, diabetes, hypertension, high cholesterol, the things that are really high in prevalence in Tasmania, so lots of people have these disorders, that's why we have an increased risk of stroke. Having said that, we're not that bad. So we have a high incidence of stroke compared to other states by 1 or 2%. We're not saying that you're 30% more likely to have a stroke because you live in Tasmania and have one of these things. We just happen to be a tiny bit ahead of the other states who also have the same problems, the same underlying risks. One of the things probably that accounts for that 1 extra % is the ageing population in Tasmania compared to other parts of the country. So age being one of the primary drivers of having a stroke in the future at some point.
So moving to Queensland won't reduce your risk of a stroke?
No comment.
Unless you change your
Yeah,
lifestyle
depends
as a
what
part
you
of
do
the
in
move.
Queensland, that's right.
Yeah, so the lifestyle impact of moving to a sunny state where you can go outside and walk more is probably going to reduce your risk of a stroke. And so that has an impact on the lifestyle you can have, obviously. But it doesn't change the underlying risk that you have, per se, from the other things that are still probably present in your body, like high blood pressure or diabetes.
Thank you for that. So, Seana, how are patients currently assessed for stroke, and what are the warning signs that someone might be having a stroke?
Yeah, sure. So who's heard of FAST? Well, now I don't need to answer this question.
All right, thanks for that.
No, we'll go on. Yes, so one of the good things about stroke is that the major symptoms that someone will show from the stroke are easily identifiable. And when you look at epidemiological studies of thousands and thousands of people that have had a stroke, and they look at the symptoms that people are presenting with, that's how they come up with the idea that FAST is a good public health message. So just to remind everyone, it's about face, so looking at facial droop. Arm is for whether people can hold both of their arms up. And speech is if people have slurred speech, so getting people to say something if you suspect that they're having a stroke. And the T stands for time. So that is that it's urgent, it's a medical emergency, and to call 000. And the important thing is to say in that call that you think someone is having a stroke, because saying that to the dispatcher causes them to take action, which will escalate the call. Whereas if you use something like, someone's had a bit of a funny turn, or they've fallen down, or something like this, it's less specific, more vague, and that really saying that keyword stroke, even if you're not really sure, it will get them there quickly and you'll get assessed. And if it's not a stroke, that's what the ambulance service is there for, really, when we're concerned about these things. So they're the major signs and symptoms that we look for with those 3 key symptoms. And then I think, that the other guys here will talk a little bit more about the actual investigations and so on that would happen within the hospital system.
So a question without notice around the time one. How critical is that time, and what are the consequences of of that fast response?
Yeah, so you know, in the world of stroke, they talk about how time is brain, and so obviously the longer you go with a blockage to the blood supply in your brain, and the other type of stroke is a hemorrhagic stroke where there's been bleeding into the brain. So the longer that goes without intervention, the more part of the brain that can die. Some of the therapies that are given, and I'll talk a little bit about that later, there are set time windows when they know that they're particularly effective. So yeah, the sooner you can get to a hospital and have the proper evaluations, the sooner you can get the treatments that can start to reopen the blood vessels and get the blood supply going again.
Okay, thank you for that. So Gary, I was talking to someone recently who's an elderly gentleman who has had trouble with blurry vision, and after some time and visits to various doctors and specialists, they've determined that it was a stroke that has caused it. He wasn't aware he had a stroke. So are there challenges in diagnosing stroke, and can people be misdiagnosed?
Yes, there are several stroke mimics. So some of the more common ones are seizures and migraines, and some infections as well can cause symptoms similar to FAST. So these are certainly challenging in an acute care setting when a patient enters the hospital, and that's where the clinical workup comes into play. So you have the physical symptoms, but if you have if a person enters the hospital, you can of course start, if they're potentially showing signs of a stroke, they can be entered into the stroke unit and they can undergo a scan. So something like a CT scan with some sort of contrast agent, so you can actually have a look and see if the symptoms that they're displaying are clinically linked to something going wrong in the brain. What was the other part of the question, sorry?
Can people be misdiagnosed?
Yeah, so with the CT scan, that can help rule out whether or not, rule in or rule out that it is a stroke that's actually causing these symptoms.
So this is all obviously happening pretty quickly when you present to hospital.
That's exactly right. So this is in that acute phase, and there's this time factor that Seana was talking a little bit about, because I think we're all going to talk a little bit more about the treatments for stroke soon, but there's a real push to get people into a CT scanner and confirm that it's a stroke within a very short time frame, so that we can start thinking about administering these treatments to reopen blood vessels if it's possible.
Sure. Okay. Thank you. So Dino, what are the major challenges or long-term consequences for those who experience a stroke?
Well, it depends on whether they get immediate treatment or not at the end of the day. As both the other speakers have said, the time element is the critical thing. So the sooner you can get the person to hospital by making some urgency in terms of the phone call and the ambulance getting there, the sooner you can get them scanned and the sooner they can be administered a treatment to remove the blood clot and restore blood flow to that part of the brain that's being damaged. So it depends a little bit on that time element. So the severity of the stroke gets worse the longer the blood clot is in there. That's the reality of it. That's why they say time is brain, so more brain damage accrues. The symptoms that people live with after a stroke, if they happen to survive, and some strokes are big enough and the people don't survive them, too much of the brain is damaged, and they cannot recover from that. Lots of people do recover though, so it's not that grim in terms of stroke recovery. The challenge is normally to do with where the blood clot has prevented blood flow from getting to in the brain and what parts of your body that part of your brain controls. So for lots of people, the symptoms are motor, so they have inability to move their muscles to control their face, hold their arms steady, like Seana said, and that over a longer time frame after the stroke has been treated, so after the FAST has happened and they've been diagnosed and treated, they're the symptoms that linger. So they're the things that people live with for a long time. And so it's the ability to control your body to do everyday tasks that are kind of the long-term consequences of stroke. The exact things that you can't do after a stroke are really dependent on where the blood clot has gone in the brain. So it is a little bit random in that sense. But for most people, it is just the ability to live normally day to day, to look after yourself day to day, to dress yourself day to day. Sometimes there are problems with swallowing or eating, depending on the kinds of muscles that have been impacted in your face, for example. So the long-term consequences do really depend on where has this blood clot gone and blocked blood flow to, and the rehabilitation that we give people is really trying to get them to learn how to use that part of their body again effectively to give them the independence and the normal mobility to go on with their life after the stroke. And we'll speak maybe a bit more to that, and Seana might a little bit later on.
Okay, so next question is for Seana. What are the current treatment strategies for stroke, and how personalised are these treatments?
Yeah, so I think we've talked a little bit about, sort of what will happen when you arrive at the hospital, and a lot of these things will be done in the emergency department around getting someone to a scanner straight away to determine what type of, if you've had a stroke and what type of stroke you've had. So, as I said before, there are two main types of stroke. So ischemic stroke, where the blood supply has been blocked, and that's about 80% of strokes, and then about 20% are hemorrhagic strokes, where there's been bleeding into the brain. And most of those, so about 15% overall, are what's called an intracerebral hemorrhage, where the blood vessels burst inside the brain. And then a very small proportion, about 5%, is what's called a subarachnoid hemorrhage, and that's where an aneurysm bursts off of a blood vessel, and that puts sort of blood over the outside of the brain. So the treatments are slightly different for each of those types of stroke, but the sort of very time-critical treatments are particularly for ischemic stroke. So there are drugs that can be given that can break up the clot, and ideally given within a few hours, so up to around 4 to 5 hours. And I say ideally because there's sort of advances being made all the time in the imaging that's done on the brain, and they're now starting to look not just at that time window, but also at how good the blood flow is and how likely it is that that part of the brain, the blood flow, is going to come back. But yeah, certainly it's within about 4 to 5 hours. So you can imagine that you sort of have to go from seeing someone having this happening to calling an ambulance, getting it there, getting them to a hospital, and getting all of these things done very quickly, which is why the time part is so important. So the other thing that's become an important part of treatment in probably the last 5 years is what's called thrombectomy, or endovascular clot retrieval. And what that is they put a very tiny catheter up through your blood vessel, usually through your leg, and they go in with a coil and pull the clot out of the brain. So it's most suitable for clots that are in the big blood vessels that lead into your brain, and that's where most of the evidence has come from. But that's been really transformative because it basically, the person goes from having these deficits you can see, the clot's pulled out, and it's completely restored. Again, it's time critical, so it needs to happen quite quickly so that the damage isn't happening in the brain. So they're the kind of two main treatment options for ischemic stroke. And then for hemorrhagic strokes, they're mostly sort of medical management around lowering people's blood pressure, but for some hemorrhagic strokes, they may do neurosurgery to go and try and remove the blood clot, and if you have an aneurysm, to close that off to stop it bleeding as well. And I think the other thing I want to talk about in terms of treatment, and Dino did refer to this as well, is that the rehabilitation that people receive afterwards is really very important. So, as Dino said, the effects that someone can have can be, varied between people, and that's really where that sort of personalisation of the rehabilitation comes in. So, you'll have physiotherapists working with people to help them regain function, speech pathologists that are around speaking, eating, swallowing, occupational therapists working to make sure the person's home is appropriate for them, trying to help people get back to work. One of the things that's quite common for people is to suffer from depression and other mental health related issues after something like a stroke in around about 20 to 30% of people. So working with neuropsychologists who are specialists in that is also really important. I'm trying to think if I've forgotten any other allied health people. I don't think I have, but allied health is really important. So that kind of support that people get after that acute phase is such an important part of people's recovery. And if you talk to people that have had a stroke before, it's a lifelong thing. This isn't something that's fixed, within 6 to 12 months. Even if you look like you're fully recovered, people suffer ongoing fatigue is a really big issue for people. Probably more than half of people don't manage to get back to work. So it's a lifelong journey, and particularly working with these allied health teams in the community is what sort of helps people to get back to living the sort of life they want to live.
Okay, thank you. Dino, Shauna may have stolen a bit of your thunder on this one, but in your experience, what's been the most significant advancement in stroke management in recent years?
Yeah, so we are still limited, is the short answer. And I won't repeat a lot of what Shauna said because you don't need to hear that again. But the advancement, I think that the biggest one in the last 5 years has been this endovascular thrombectomy, where they take a filament, stick it up into your brain and pull the clot out. That means the clot is out straight away. When we give a clot-busting drug, it takes a while for that drug to work to break the clot apart before blood flow is restored. So the screening that's happening, and we've got the acute stroke unit at the Royal Hobart Hospital. Was it 4 years ago, Gary, you said that they did their first endovascular thrombectomy, basically?
This might have been 3 years ago, yeah.
So this is a relatively new development in Tasmania in particular. It's only available at the RHH, unfortunately, because it is not as easy as giving someone a drug intravenously, which can be done in lots of other parts, in lots of other hospitals that don't have high-tech equipment available to work with. Because to do the endovascular thrombectomy where the filament goes up, you have to see where the clot is, you have to see where the filament is, to make sure you're grabbing the right thing in the right place and pulling it out. And so that takes a lot of machines around the person and around the surgeon doing that to actually make it happen. But it is something that is proving to be quite effective for these really large blood clots, the large blood vessel blockages. And more recently, people are trialling the combination of endovascular thrombectomy, which can get the big clot out, but there might be little clots that have gone downstream already and blocked small vessels, and then giving a clot-busting drug as well. So there is a combined therapy approach, and the clot-busting drugs are being redeveloped. As you can imagine, drug companies are pretty interested in this space. And so there are newer generations of clot-busting medications coming out that have less off-target effects, less bleeds in other part of the body, for example, and work more quickly to break the clot apart. So there is some advancement in the clinical management in terms of getting the clot removed. But in terms of hemorrhagic stroke, I don't know much that has really changed in that space for a very long time, because it is a lot harder to treat that kind of stroke. All we can do is patch the blood vessel up and stop the blood from coming out. That's kind of it. With clot retrieval or removal, we've got two options, but again, that's it. The primary problem is trying to restore or effective blood flow to that part of the brain again. And beyond that, as we'll talk about a bit later, we can't do much else yet. So we can take the clot out, but then we're kind of stuck with helping people beyond that process to give them a drug that might help their brain recover. And that's some of the work that Gary and I are doing, trying to understand whether there are potential novel ways of giving post-stroke therapy to help people with their recovery. So we'll speak about that a bit later on.
Interestingly, one of the research projects that the Foundation's funding at the moment is a physiotherapist working with people who have suffered a stroke, is finding some people recover better than others through the process of receiving the physiotherapy. And the suspicion is that it may be to do with blood pressure. So this is funding a research for that physiotherapist to do ongoing monitoring of blood pressure of stroke patients as they go through that physiotherapy rehabilitation to see if there's a link. And that's one of those small projects that we fund that may go nowhere, but it may also, and it's a voyage of discovery, may be one of those ones that actually turns over a leaf that is quite enlightening. So it can be very interesting. So thank you. So Gary, what are the limitations of current treatments and what more do you think can be done? And again, the thunder's probably already been stolen on a fair bit of that.
Sorry, Gary.
No, that's all right. I'll try and add a little bit more to that. So these things sound great: thrombolysis and thrombectomy. Going in and grabbing a clot sounds well. You need somebody who's qualified and capable of doing it, obviously.
Sounds like a big navigation exercise, nothing else, finding your way to the right spot.
That's right. But the fact of the matter is that the vast majority of patients are not actually eligible to receive these therapies. And I think this is a really critical point. So by that I mean there are certain, if you're over a certain age, for example, you can't receive these therapies. And I can't remember the exact age cutoff.
They do try to. I'm not sure about current guidelines. Maybe over 85.
I think over 85. But when we think about stroke, a large proportion of the people that have stroke are over 85. When you add it up, I think something along the lines of less than 10% of patients can receive these therapies. So we're talking about a very large percentage of people with stroke who are effectively not receiving acute therapy for stroke. So that's one bottleneck. Of course, Sean has talked a little bit about the fact that there are actually a lot of fantastic therapies post-stroke, occupational therapy, physical therapy, speech therapy. The other quite interesting thing about the brain that I wanted to mention is that it actually has a remarkable capacity for self-repair. So if you do nothing else, there's a vague statistic, and I struggle to find the primary literature for this, but you will effectively recover 70% of what you lost during your initial stroke. Now, if you have a very large stroke, that 30% of deficit that you're left with is still rather large. If you have a relatively small stroke, 30% deficit that you're left with might not be very bad at all. It might be quite manageable. And we've touched a little bit today on the large variety of strokes that makes things challenging. You mentioned before you had a friend who had a very sort of minor symptoms, and this is not something that would be comparable to a very large stroke. One other last thing I wanted to touch on, in the patients that do receive these thrombectomy or thrombolysis to clear the blockage, we tend to see that we do get the blockage cleared and blood flow going back through the large vessel that was blocked. But quite often we're actually finding that the very small vessels of the brain are still not receiving the blood supply. And I've got a few slides a little later on which will touch on that a little bit more. But these drugs are fantastic and help a lot of people, but they're not necessarily a magic bullet. And in up to about a third of the patients that actually receive these drugs, they're not getting full blood flow back through all of the blood vessels in their brain. So I think from all the things all of us have said, you can probably see there's a lot of challenges still remaining to really improve brain repair post-stroke, and we'll all talk a little bit more about that.
It's an interesting thing that the blood flow to the smaller vessels doesn't recover even though the blockage has been moved. So no doubt that's part of what research is looking at. So Seana, what promising research or technologies do you believe will shape the future of stroke management that we've probably not already alluded to?
Yeah, I mean, I think there are a few different things. So the advances in what we call telehealth have been really important. And so this is basically where doctors in a rural or remote hospital can phone into a major hospital where you've kind of got all the specialties, so the neurologists, the experts in stroke, the interventional neuroradiologists that can pull the clot out, and they can do the types of specialised assessments that are needed to figure out if this person has had a stroke and should they be transferred to another hospital when these things can happen. So Tasmania the north of Tasmania is connected to Victoria for telehealth, whereas in the south of the state we have a 24/7 service anyway. But what that basically does is allows people that live anywhere to get access to the diagnosis that you would need for a stroke. And there's efforts to create those telehealth networks all around the country. So they're pretty well established in kind of every state, and some of them are working across different jurisdictions as well. So telehealth has been a really important part of sort of advances to that. But I would also just like to mention something that's slightly less, fancy or, sounds exciting. But the thing we know really works best for people is being managed in what's called a stroke unit. And I think that was mentioned before. And basically what that is it's a part of the hospital where they're dedicated to treating people that have had a stroke. And it's been shown across lots of studies internationally that there's some sort of X factor of this. They can't figure out exactly what the component is that makes this so effective, but having dedicated nurses, doctors, allied health staff that can manage people in this sort of way improves people's outcomes enormously on a stroke unit. The problem is that most stroke units in the country don't have enough beds for people, so a lot of people just don't get treated on a stroke unit. So here at the Royal, the figures vary from year to year, but probably about 30% of people just never make it to the stroke unit. So things like that aren't so as exciting for people, but that, you know, we really should advocate for the hospitals having enough beds to get people treated in these places that we know have really good outcomes is very important.
Let's not try and poke that there.
I think we should.
Well, I agree we should. There's a lot of poking required and we don't seem to be getting too far, but that's probably for another conversation. So we might move on to Seana, your research focused on secondary prevention of strokes and the evaluation of the stroke outreach or STOP program.
Yep.
Could you elaborate on how these initiatives are improving stroke care and patient outcomes in Tasmania?
Yeah, sure. I think we're going to go to our slides, are we?
Yeah,
Yep.
I think we're actually in a slightly different order.
Okay. That's all right.
Oh, okay. Do you
Yes.
want to change the order for the...
Yeah, we could do that. Because we realised after we
Yes.
had a chat that we actually were all covering from the diagnosis through to what I'm looking at, which is recovery. So we've reordered them so that it makes a little bit more sense. So we'll start with
Okay.
Gary.
I think I'm going first to talk about improvements in diagnosis, followed by Dino, and then
Okay.
I'll
Sorry
pick
to
up
steal
afterwards.
your-
Sorry about that. Yeah. And the slides are.
And we're going to get away so you can see the screen, so we'll just sit down the front for a few minutes.
Slide over here. Okay.
Yeah, who does that?
Do you want me to push
Oh,
it?
yeah.
Oh, sorry.
Alright. The end slideshow, that's
This should work.
okay, here we go. See it
There you go.
Oh, great, okay.
Yeah, I took it down there.
Deepen.
I reckon just stand down there so that they can capture my camera nice and easily up there.
Okay, so now's my little chance to talk to you a little bit about the research that the RHHRF funded that I've been working on over the last few years. So I just wanted to sort of bring up this figure. I think our laser pointer's not working, but the brain is chock-a-block full of blood vessels. 600 kilometres of blood vessels in an individual human brain, and that is absolutely mind-blowing. I tend to walk around and think about that as I look at people. Just we're all a ball of blood vessels with some muscles on top at the end of the day. And when you look at so this here is a picture of a brain slice and cross section like this. So this is looking down in this sort of orientation, and what you can see is that there's large vessels, and from those large vessels, you have smaller vessels which peel off them basically. And as you can see in a slice of a brain, it is absolutely full of blood vessels. This is just a cartoon version of that. So the way the vessels are organised in the brain is that blood comes through from arteries, which generally, but not some come internally, but generally speaking, they come from outside the brain and then they dive into the brain from the top down. They turn into a smaller vessel called an arteriole, and something like this would be an arteriole. The arterioles then split into capillaries. These capillaries are all of this other stuff, all of these other vessels, and the vast majority of the vessels in our brain are capillaries. These then drain into venules and into veins. Now, why does the brain have so many blood vessels? Basically because we don't have energy stores in the brain. So, for example, in our muscle, we have local energy stores that the muscle can access. The brain does not store energy. The other reason that we have so many blood vessels is that the neurons in our brain are incredibly energy hungry. They require a constant source of energy. So if you cut off blood supply for even a couple of minutes, those neurons start to become dysfunctional. That's why stroke is such a big problem for a brain. And the longer the blood supply is cut off, the more that the injury spreads around the brain. So our brain is only 2% of our body weight, but requires 20% of our energy. This is a little bit of a tricky diagram, but I'm going to try and explain to you that blood vessels are not just simple channels for blood to just pump through. They're a little bit more complex than that. So blood vessels are surrounded by other types of cells. So on large blood vessels, for example, you can see these red rings. These red rings are what we call smooth muscle cells. Smooth muscle cells are contractile. And the reason that they need to be contractile is because you do not just want blood flooding through the brain at 100 miles an hour all of the time. The movement of blood throughout the brain needs to be controlled. And it's controlled by these contractile cells, which can effectively open and close and direct blood flow to where it's needed. There's also contractile cells on the smaller vessels of the brain, the capillaries, and we call these pericytes. Pericyte sounds like a little complicated name, but it effectively, peri just means around. We have the term peri for a lot of things. It's just a Latin word that means around. And cyte means cell. So a pericyte is a cell that sits around capillaries. And in the smaller vessels, this microvascular network, that what we call the capillaries, the pericytes help direct flow in different directions. So if a certain part of the brain needs blood, the pericytes will relax and allow blood to flow through the network and head towards where it's needed most. And if you have any questions about that, I'll be happy to answer them. This is a cartoon version of one of these pericytes on a blood vessel, and I just wanted to quickly show you an animation of how these pericytes can clamp shut on a blood vessel. So this is the pericyte here, and in a second, this is not my work, this has come from a research paper from a different group. They've applied a drug called a vasoconstrictor, and what this vasoconstrictor has done is you can see that it's changed the diameter of the blood vessel. And the vasoconstrictor has acted on the pericyte. So the pericyte has constricted the blood vessel. That's how blood flow is controlled through the brain. And later on, this pericyte will likely relax and respond to a relaxant signal to change blood flow. So one of the things I've been doing in the RHHRF funded project is researching this new line of research from other research groups that has shown that after stroke, when we have a blockage, and the blockage is usually up in the larger vessels, what happens is that this affects the pericytes on the smaller vessels. And by affects, I mean it causes the pericytes to clamp shut. And in that position, they die, and that means that when we open the really large vessels, the pericytes prevent blood flow from coming back through the much, much smaller vessels. Now, the interesting thing about pericytes is that when they undergo this process of clamping shut, they release a protein. So this is a molecule that they express inside of them. When they clamp shut and start to die, they release it. And this protein can end up back in the bloodstream. So what the RHHRF funded project was about was finding a way that we could develop a test to measure this protein, because the amount of this protein is related to the amount of injury to the small vessels of the brain. And this is really, really important because the amount of injury, as we were saying before, when you reopen the large blood vessels, you don't always get reflow throughout the entire network. So the amount of this protein tells us how much of the reflow we're getting in individual patient brains. So a way that you can think about, I think that's my last slide, but a way that you can think about this is that for heart disease, for heart attack, we have the ability to measure something in the blood called troponin. And this enables clinicians to tell if a person is experiencing a heart attack. What I hope that this blood test can do is to help clinicians identify that a person is experiencing a stroke and the severity of that stroke based on the amount of this molecule that we're able to detect. So I'm a biochemist by training, and my job is effectively to take blood samples from patients and to develop a test which is capable of picking up this piece of protein from the blood. And we do this using antibodies, and we had to basically spend a lot of time in a lab with pipettes and blood samples, putting the protein onto the antibodies and then seeing if it correlates to how severe the stroke was in the first place. And effectively the goal here is to have the ability to very quickly take a blood sample from a patient that comes into the hospital and see if there's a spike in the amount of this protein that's being released from pericytes, which may indicate that a person's having a stroke. And that could be particularly important in, for example, rural care settings where it's very, very difficult to get a patient to a hospital quickly. So we'll be armed with a little bit more knowledge by the time that this person reaches the clinic. I have a question. Here we go. Would you like this?
Test for anything else, such as, if people are having any issues prior, will this test show?
So that's a really good question. So another line of research that I work on is dementia, and the clue that I got to this protein potentially going up when pericytes are injured is from a line of research showing that pericytes are injured in dementia as well. And some researchers from America have developed a test that can measure this protein, and I'm building off of that work. So yes, there are other reasons which may cause pericytes to die. With something like dementia, which is chronic and occurs over a period of 10 to 15 years, they're seeing subtle increases in this over time. With something like a major stroke, it would be a large spike very quickly because, as I said before, the cells die incredibly quickly after stroke. I don't want to take up too much time from the other speakers, so I think I'll leave it there for now, and happy to take any other questions later.
My name's Dino. I work with ultrasound. So my expertise is understanding how blood vessels work. Stroke is a part of that kind of research that we do. And a lot of the work that we focus on uses ultrasound to look at tissues inside the body, and I care about blood vessels. So we use ultrasound to look inside the body to measure blood vessels and measure blood flow through blood vessels. Now, most of you have probably seen ultrasound in some shape, way or form, whether you've had a baby in utero that you're looking at, anxiously expecting them to come out sometime soon. The fun story that I have, which my wife hates, is I've got 3 daughters. When we have gone to look at the scans of the babies at week 20, much to my wife's annoyance, have been more interested in the ultrasound machine than what was being shown. And that's because I think this is a really cool technique. Ultrasound is non-invasive, which means it doesn't cause you any harm. Ultrasound is now more portable than what that image looks like. You don't need a giant cart that someone needs to wheel around in a hospital to use it. They are now laptop-sized machines. They can now even work on your iPhone if you have the right plug-in adapter for it. So ultrasound is really, really useful for us to see inside the body. And the way that it works is it sends out sound waves from an ultrasound probe. The sound waves hit whatever is underneath that probe, like our object that's in blue there. They reflect the sound. The thing that sent the sound out in the first place detects that reflected sound and gives us the image on the machine. So that's the basics of it. The sound waves come out, they hit something, they bounce back. Now, we don't just use normal ultrasound, as we're shown here, to look at like babies in utero. We use something called contrast-enhanced ultrasound, which is a bit of a mouthful to say. The short version of it is that we have something that we inject into people's blood vessels to enable us to visualize the blood vessels, not the baby's head, not the baby's bones, but the actual blood vessels themselves, which are really hard to see normally. So the thing that I've got on the left-hand side up there is what's called a phospholipid microbubble. Phospholipids are a type of fat. They are basically what all of your cells are made out of inside your body. So when we introduce these into someone's blood, we're not introducing some foreign substance into the body. Your body's already made up of lots of it. The reason we put it in to blood vessels is because these things are tiny. They're microbubbles, so they're very, very small. They fit through all the blood vessels inside the body, and they are a phospholipid shell, think like a balloon, and they have an inert gas inside of them. And that's the critical part of the imaging that we do and the therapeutic potential of this kind of approach that I'll tell you about in a second. But essentially, when you put these things into the bloodstream, and this is a little cartoon that I've got from someone else's work online. This is showing us one capillary that Gary was talking about. This is showing us some red blood cells moving through, and there's an occasional microbubble that pops into view. I'll just play that video and hopefully it will work. And it's showing you the sound waves are coming through from outside the brain, so we can do ultrasound imaging of the brain. And as the bubbles as the ultrasound interacts with the microbubbles, they do an amazing thing. Our cells don't do this, but microbubbles do, which is why we put them in there. And what they do is expand and contract in size. So as the sound wave passes through them, they get bigger and smaller physically. And that is what allows us to hear them ringing inside the blood vessels so we can see where they're going. It's the sound waves that hit them, activate them to basically bounce and ring in the blood vessels, and we can see where they're flowing. The other thing that I want to really work on, and this is some of the work that's been funded by the Royal Hobart Hospital Research Foundation, follows on from what Gary said. Our capillaries remain shut after a stroke has been removed. Even when the large artery is open and the clot's been taken out, the small vessels stay shut. I'll play that video again because it's showing you what we think is happening. When you have these microbubbles going through, they change in size inside the capillary, and they are able to actually massage the blood vessel from the inside. So what we want to do is use something like these microbubbles, which are already used for imaging blood flow in people's hearts. They're already available for us to go in and actually trial whether this does something after a stroke has been cleared out of the brain and you've got problems with the capillaries. We want to get these bubbles into those capillaries, and we want to use awesome ultrasound, non-invasive ultrasound, to open those capillaries back up. Because fundamentally, if we can open those capillaries back up, they are the blood vessels that deliver glucose and oxygen to the brain. And unless you can restore effective blood flow through those capillaries, you can't help a person recover better from that stroke, because the drugs can't get there that you might give someone via their blood. They just can't get there. If the drugs can't get there, they can't help the brain recover. If the glucose and oxygen aren't returning in high enough amount, you can't help the brain recover. So we want to use ultrasound and these tiny, tiny bubbles that we can put into your bloodstream to help your blood vessels reopen after a stroke. Now that's really important because that's the first part of the story. And that plate. The second part of the story is I can put drugs into those microbubbles. So those microbubbles can essentially end up being our tiny drug-filled capsules inside the bloodstream. So one of the big problems of treating a stroke with a drug of some sort is if you want to lower someone's blood pressure after they've had a stroke, that's fine, that you can give them a drug and that will work in the rest of the body. But if you want to help their brain recover from that stroke by giving them a neuroprotective drug that needs to get into the brain and work, the amount of drug you have to give by injecting it into one of their big blood vessels in the arm is enormous for it to get into the brain. And even if you can get it into the brain, the amount of the drug that is required usually has off-target effects in other parts of the body. So it might change how your heart is working, or it might stress your liver at a time when the rest of your body is stressed from the stroke. So what we are hoping to do is essentially get our microbubbles, and our images on the left-hand side over there is what they look like under a microscope. The top image is the bubble shell that you can see, and the bottom image is us loading those microbubbles, the same ones, with a fluorescent drug. So we can look at it under a microscope and say, there it is, we can actually get a drug into the capsule. And the cool thing is, we can then use ultrasound again to not just open blood vessels, we can use ultrasound to pop those microbubbles. So if we can pop those microbubbles once they're in the damaged vessels, we can release that drug to the vessels that need the repair and to the parts of the brain that need that drug for the recovery. So last time I spoke about this, I think Heather was still the CEO of the RHHRF, and she called it science fiction. And I'll correct her and say it's not science fiction, it's science. There's no fiction about it. This is what we are actively working on, and we are hoping to be able to deliver this in the next 5 to 10 years into the clinic to be able to actually help people recover better from a stroke beyond just removing the clot. Because ultimately, if we can improve the blood flow through the capillary network, we can improve nutrient delivery back to the damaged part of the brain to help it recover, but also deliver drugs directly to the damaged part of the brain to help it recover better.
So Dino, that 30% that your brain doesn't recover from a stroke, is this actively looking to reduce that 30%?
Absolutely. That would be the goal and the dream of the research. Whether we can get that to zero is a big question that we don't know the answer to until a lot more work gets done. So we're at the very early stages of this, but we're getting some very promising results from the drugs that we're working with, like Deepen that was mentioned before. That drug helps cells survive when they are nutrient deprived. So that's why we're working with that drug, for example. I won't talk much more about that. It's one of the drugs in a number of experiments that we're testing.
Yeah, what I was asking, what I was wondering is that technology, if someone's got, say, white spots in their brain where they've had little bits of cell death, would that technology be something that could be used to reverse that?
Potentially, it depends on what's causing the white spots. But essentially, beyond stroke, if we can package drugs into tiny microbubbles and put an ultrasound probe over that part of the brain or the liver or the kidney, we can target drug delivery to that part of the body using this to maximise the effectiveness of the drugs and reduce the off-target effects. Now, what drugs will work for the white spots, I don't know, but that would be something that we could explore further down the track. One great example of this having real potential in the future is brain cancer. So beyond stroke, brain cancer is one of those really difficult things to treat at the moment because all the capillaries that Gary spoke about, they prevent drugs from going into the brain as well. So they suit a purpose by defending our brain from what's in our blood, but for brain cancer, when you want to get things into the brain, those blood vessels become really problematic. And ultrasound can disrupt them as well a little bit to get more drugs to go into the brain. And if we can package them, we might be able to help in that context as well. So it's a really exciting area of research that we're working on. And it all started with funding from the RHHRF in 2018. So I'm really thankful that we were able to start some of this work, and now it's actually getting to the point where we're seeing some real tangible outcomes from it.
Thanks, Dino. That's fascinating. So, throw over to Seana.
I'm so low tech after these guys. So the project that we were funded to do for the Royal Hobart Hospital Research Foundation, momentarily forgot one of those words there. So yeah, it was more a low-tech approach to how could we support people after stroke. And it was working in partnership with the Stroke Foundation that I do a lot of work with. And the project was actually led by a junior researcher that was a part of my team who's now moved up to Darwin. So what we were doing was we were evaluating an existing program that the Stroke Foundation had, which was called the Stroke Outreach Program, or STOP. And what this was responding to, and the little graphic there, is that the Stroke Foundation do a lot of work looking at the type of care that people are receiving when they're in hospital and after they leave hospital as well. And when you look at that, you can see that around about 30 to 40% of people don't get a lot of the basic types of things that I was talking about before. So about 30% of people don't get what's called a discharge care plan. This has improved a little bit since those figures now. A lot of people are not assessed for rehabilitation, and about 30% of people say they don't receive any information about their risk factors when they leave hospital. So in some other groups of people that have been hospitalised, so people with cancer and people with some mental health conditions, they found that a very brief telephone call to have a discussion with people about what's happened to them and what's going to happen next can decrease things like hospital readmissions and also increases people's satisfaction with the treatment they've received. The Stroke Foundation has been fortunate enough to receive funding from the Tasmanian government to run this service in Tasmania since 2019. And although the service existed, it hadn't been evaluated, so we didn't really know if many people were receiving it or what kinds of outcomes it would have. So this is the way the system worked at the time, and I'll tell you a little bit about what it's like now. So a person comes into hospital and they can be referred to this program STOP when they're discharged. So it can be the discharge from the acute care hospital or from rehabilitation. And the person referring them, so this could be a neurologist, a general practitioner, or someone from the rehabilitation setting, fills in an online portal about the person and their risk factors and what their kind of clinical needs are. That goes to the team at the Stroke Foundation, and they call the person within about 3 weeks of their discharge. And they have a brief telephone call with them, so they ask them if they know what their risk factors are. They do a screening instrument to see if they're suffering from symptoms of depression and anxiety. They talk about whether they have the follow-up appointments they might need, and then can put in place other referrals if needed. And then they write a summary letter about the discussion they've had and send that to the person's GP. So quite simple intervention that's led by people over the telephone. So what we were interested in doing is evaluating this service, and we did this using quantitative, so looking at numbers, and qualitative by having discussions with people. So what we found in the quantitative part of what we did was we did a little survey of around about 20 health professionals that the Stroke Foundation told us knew about the service and should be referring to it. And we found that of those people, about 30% didn't actually know about the service. When we then had discussions with some of these health professionals, but also around 10 people who had received these telephone calls after stroke, people talked about the fact that it was good because it reinforced information that had potentially been provided in hospital or provided new information for people. That the people themselves felt like it was a safety net and that they felt supported, that people did really care about what happened to them when they left hospital. But some of the negative things we heard about the program was that for health professionals, the actual process of referring took quite a lot of time through that online portal, and they had to get consent from the people before they left hospital to pass their information to this other organisation. There was some concern that the call within 3 weeks was a bit too soon and maybe it needed to be in the longer term. And also through the interviews we conducted, we realised that quite a lot of people that had been phoned by the service, some of them didn't know they'd had a stroke, they weren't aware that that's what had happened to them, they seemed very unaware of their risk factors and so on. And some people also expressed frustration about the nature of the support that could be provided to them. So it was very focused on risk factors, but a lot of people need support with practical things, social things, getting in touch with Centrelink, organising things like this, and that's not really what the service was to provide from the Stroke Foundation. We also did something called data linkage, where we took the whole database of people that we had, and it was around about 400 people that had been provided with this service, and we linked it back to a big data set we have of every stroke that happened in Tasmania between 2007 and 2020, so it's a big data set. And what we could see from that was only about 20% of people during this time frame had actually been referred, so that kind of aligns with what we found at the top. And we saw that the people that had been referred, they tended to more often be men and they were a bit younger than the people that weren't referred, but they seemed to have similar levels of readmission, so maybe slightly less in the group that were referred. So what next for this program? So we worked closely with the Stroke Foundation and we provided them with the information that we've received through this assessment, and over the course of the past couple of years they've rebranded this service and it's now called the Stroke Navigator. So it's still running in Tasmania. They've moved out to an opt-out referral system so more people can be referred in without the barriers of consent. The Stroke Foundation have invested a lot of time in promotion of the service across different health settings and out in the community, and they are trying to broaden that discussion to meet the needs of the people that they're talking to. And they've also created a lot more links within the system to some of their other services. So they have, for example, a behaviour change program called Living Well After Stroke, and they've now got good referral pathways between these two systems. So yeah, that's an overview of this quite low-tech solution that had been put in place by the Stroke Foundation and funded by the Tasmanian government, and it was great to have the support of the foundation so that we could evaluate it and help it to be improved so that it could keep helping people after stroke.
Thank you for that, Seana, and thank you to all three of you for your presentations. I found them really easy to follow and very informative. I'm aware we're at our finish time. If you do need to leave, feel free to, but I'd like to still take the opportunity to throw it open to some questions. I'd like to take a seat. If people have questions they would like to ask of our presenters. Okay, thank you. It's sorry.
I'll just say the whole section. You can answer whichever one. But I was just interested in terms of stroke management and stroke recovery is exercise, diet, supplements, lifestyle, sleep, socials, things like caffeine, as well as heat, like saunas or anything like that. So.
I want to have a crack at that one.
Oh, well, I think, things at the top of your list you mentioned, of course, exercise, physical activity, really important to help people recover, great for lots of risk factors for stroke, so lowering blood pressure, managing diabetes. I think we increasingly understand the importance of sleep as part of cardiovascular health and managing that as well. It's a bit boring to say, follow all the guidelines that we should follow around our diet and those sorts of things. They're all really key messages. I don't know as much around the evidence of things as you mentioned, sort of around saunas. I did go in the sauna tents last week that they had for National Science Week. That was That was fun. I don't know if it was good for my brain, maybe. You sit and talk to people, and that was good for my brain. That's good, cognitive activity. So yeah, I don't know if...
I can't add any insight into saunas. In terms of the longer term recovery, one of the things I would say is there is an experimental treatment for right after a stroke where they go the other way. Rather than heating your body up, which increases your metabolism and drives more nutrients needed to all the cells to keep them working, there's something that they're trialling for acute stroke therapy, which is hypothermia. So that is where they lower your body temperature and hopefully lower your brain temperature to lower the metabolism to help prevent that nutrient loss from driving more cell death in your brain. Now, annoyingly, the body is built to resist hypothermia. And so it fights back and tries to heat things up. So they haven't had as much success to cool the brain down as what they'd like because it's difficult to do because the body fights back and tries to heat it back up because that's one of the things our body tries to regulate. But saunas, I have no idea in terms of if that's a therapeutic potential after.
That's where I was asking. I was like, are saunas potentially dangerous? You know, because like maybe they're too hot if somebody's had a stroke. And
It
like,
probably
I feel
depends
dizzy.
on what
It
stage.
was just like,
yeah.
you know, I was just they were questioning it.
I think acutely after a stroke, no go.
Yes.
But in terms of if it helps you probably manage your stress and helps you get out into the community and talk to people for your mental health, it might be a great thing which might help your recovery as well. But that's anecdotal and not advice that I'm providing right now.
Any other questions before yeah?
I was just going to ask, is it true or is it just a sort of fallacy that once someone's had one stroke, they're likely to have another one?
Yes, you Russian.
Yeah, I can speak to that.
Please?
Sorry?
Could you repeat the question, please?
If you have one stroke, are you more likely to have another one? Absolutely true. So I have a personal connection with this, which is why I jumped at the microphone. My grandmother went through this. So she had her first stroke at 78. It was a big one, took her a long time of rehabilitation to recover from that. And then soon after that had her second stroke in the same blood vessel, basically. So strokes damage blood vessels. Damaged blood vessels make new strokes more likely because of the things that Gary spoke about. Because they are damaged, more of the clotting factors stick to them. Those clotting factors eventually, when there's enough of them, break off and go and block the same blood vessels again. That's not to say that the strokes will happen in the same spot, but that's kind of what seems to be the case. So yes, having one stroke absolutely increases your chances of having a recurrent stroke, which is typically after the third one. My grandmother passed away. It was too big and there was too much brain damage after that point. So yes, absolutely, there is a greater chance of having another stroke afterwards, which is why lifestyle interventions, rehabilitation, doing all the right things, the good for you things are important to reduce that risk as much as possible.
Okay, thank you for that. Any further questions? Nope. Okay.
Actually, I'll ask one. Has anybody been researching neurotechnology and nanotechnology? What it's going to be like for brains in the future? How regulated is that going to be, you know?
Gary.
So your question is about nanotechnology?
Well, it's neurotechnology on nanotech. I just wondered if anybody had been doing any research into neurotechnology in the brain, nanotechnology, and how that might interact with neurons. You know, I'm just throwing it
Yeah,
out
no, I wish I could answer this question, but I really don't know much about nanotechnology. I would say that what Dino is doing is technically on the scale of nanotechnology.
Almost.
They're not robots, obviously.
No.
It sounds like Dino.
Yeah, so I work in microtechnology, so the next scale down from that is nano. So micro means 1,000 times smaller than a millimetre. Nano means another 1,000 times smaller than a micro. So this is very, very small particles. I know a little bit about the space, but I'm not up 100% with the literature, but there is no chance we're going to develop nano robots anytime soon. But what people are doing is using nanomaterials to enable us to image structures in the brain a lot better. So they can provide contrast to other tissues to let us see into the brain at a very small, fine detail. And what they can also do is essentially coat that nanomaterial to help drugs bind to it. So there are certain nanomaterials that will stick to certain cells inside the body because of the interactions they have. And if they can bind the drug to that nanomaterial, they can target the delivery of that drug using that approach as well, similar to my microbubbles. That doesn't require ultrasound. That is just giving that nanomaterial, drug-coated, that can help increase drug delivery. That is very experimental at this stage, so I wouldn't expect anything to be hitting the market anytime soon. But the nano space is really all about nanomaterials, advanced nanomaterials, so not the things we sort of can buy off the shelf. These are manufactured high-end nano products that have very specific chemical compositions that can help, for example, drug delivery and imaging in particular. So that's kind of where we're at with that work at the moment.
Thank you for that. We'll draw it to a close there. Thank you, Dino, Seana and Gary, for your time tonight. It's been a fascinating conversation. I've found it easy to understand, which is good. You've done a good job at bringing it down to my level at least. So the Royal Hobart Hospital Research Foundation has a wonderful reputation for funding innovative research to create better health outcomes for Tasmanians. Since 1997, we've provided more than $11.5 million to fund and support research into dementia, cancer, cardiothoracic diseases, neurological conditions and so much more. We've funded approximately 350 research projects over that time. As you heard tonight, projects for each of the three presenters have been supported by the foundation to undertake their research. Every study that's funded is directly aimed at benefiting the health and well-being of our local community. But as you can imagine, I think it has global ramifications as well. What's achieved in any one part of the world can be picked up in the rest of the world and adopted. Again, I'd like to thank St Luke's for making this space available to us. It's a fantastic venue, it's a fantastic building, and also AbbVie, who provide us with some funding to put these events on. We'd like to thank everyone for supporting local medical research in Tasmania. We'd certainly appreciate any donations that you would like to make to the foundation, and you can do that by Googling Royal Hobart Hospital Research Foundation, or RHHRF will get you there, to enable us to continue to fund research into the future. Thank you for coming along. Again, in 3 weeks' time, we have our next Research Matters event on women's health. So you can go to our website and grab the details of that and register online. So thank you for attending and have a great evening.
Thank you.
And thank you for our presenters.